This concept map is geared towards illustrating specific musculoskeletal injuries. I'll go over sprains, strains, and fractures. And by dissecting these injuries, we'll talk about the serious complications that may arise if treatment is not provided appropriately and immediately. Complications such as compartment syndrome, rhabdomyolysis, and crush injury. And these complications will result in frequent patient monitoring to assure the patient's blood circulation is adequate.
To start, I will talk about the differences between a strain and a sprain, which can be sometimes easy to forget the difference. A sprain is a tear or an injury to a ligament, and ligaments connect bone to bone. And swelling is caused by the inflammatory response due to the release of histamine that increases the permeability, causing shifting of fluid. There are three types of sprains. You can stretch the ligament, you can tear it slightly, or you can tear it completely. With strains, it is about tendons in your muscles. So it's a tear to your tendon or your muscle, and tendons connect muscle to bone. And they are typically caused by a sudden forced motion that results in the tendon or the muscle to become stretched beyond its normal capacity. Severe tears are accompanied by bleeding and swelling. And with sprains and strains, they have similar signs and symptoms by having discoloration of the skin. There's edema, there's weakness, you have soreness, numbing, decreased joint mobility, and decreased weight bearing. The treatment for both a sprain and a strain are strongly suggested by Price for prevention, protection, rest, ice, compression, and elevation, all in tune of obtaining the goal of pain relief and healing. So moving on to the bottom left of the concept map, we'll talk about fractures, which is a more intense musculoskeletal injury. And a fracture is where there's a break in the bone. And this happens when a force is greater than the bone can withstand, and it also depends on the density of the bone. Risks of a fracture can be highly increased by sports injuries, falls, drugs and alcohol, osteoporosis, which is a really big deal, immaturity of the bone, and bone tumors. With osteoporosis, it is a huge risk for a fracture, and it is recommended for diagnosed patients to take alendronate. And alendronate helps treat the osteoporosis, and the patient must take the medication with a full glass of water in the morning and at the same time every day. The patient must not drink or eat anything 30 minutes after the medication, and to avoid lying down directly afterwards to avoid gastrointestinal effects such as esophageal irritation. In terms of types, there are four. You can have an open fracture, a closed, comminuted, or a green stick. The open is, you can see a picture of it in the bottom left corner. It is damage to the tissue in addition to the fracture. A closed, which is right next to the picture of on the left, and it is no penetration of the skin or soft tissues. A comminuted fracture is a bone when bone fragments are separated. Green stick, it perforates the side of a periosteum, and it's typically a fracture in a young, soft bone in which the bone bends and breaks. So with a fracture, you would typically feel pain, tenderness, weakness. You might hear some crepitus. You will obviously see the local deformity. It's abnormal. The positioning is off, especially if it's an open type fracture. Then it could be clear to see that something is wrong. In terms of treating a fracture, initiating Price like with a sprain or a strain. It may be beneficial in pain relief and healing. Some may need reduction assistant, which is realignment of the bone or bone fragments by manipulation, which usually requires sedation or anesthesia. In an open reduction, the fragments are exposed surgically by dissecting the tissues. And in a closed reduction, the manipulation of the bone fragments without surgical exposure of the fragments. So, a closed reduction of fractures is usually maintained by casting, but some fractures only require a splint or a sling. Moderate or severe fractures are immobilized immediately by splinting. Immobilization with a non rigid or non circumferential device to decrease pain and to prevent further injury to soft tissues by unstable fractures. When fractures are severely damaged, a total replacement may occur. Typically, hip replacements require positioning on the non operative side with the legs abducted. And abduction is maintained when the patient is in a supine position or positioned on the non operative side. Internal and external rotation, adduction, or lying on the side on the operative side is avoided just to prevent displacement of the prosthesis. And lastly, amputation may have to be an option if the injury is just unfixable or incapable of managing and causing havoc and infection. Branching off of fractures, we'll go up towards compartment syndrome. And the best way to put this would be to think of a cast. So, when pressure within the muscles build to dangerous levels inside of the cast, it will decrease blood flow. It then prevents nourishment and oxygen from reaching nerve and muscle cells, which then causes severe pain and numbness and tingling, and there'll be pale and cool extremities, and then the nurse should definitely check the capillary refill. A normal capillary refill time is usually less than 2 seconds. So if the refill time is longer than 2 seconds, it typically suggests poor perfusion due to peripheral vasoconstriction. Compartment syndrome can be either acute or chronic. Acute is typically a medical emergency and usually develops after a severe injury, such as like a car accident or a broken bone. And conditions that may bring on acute compartment syndrome would be trauma, edema related. It could be a clotting issue, or it can be an external compression issue with the cast or tight bandaging. In chronic compartment syndrome, it's not typically a medical emergency. There is pain and swelling, and it's usually caused by exercise. And athletes who participate in activities with repetitive motions, such as running, biking, or swimming, they're more likely to develop chronic compartment syndrome. And it's usually relieved by discontinuing the exercise, and it's not dangerous. Compartment syndrome is typically a localized injury, and for the signs and symptoms, there's an easy way to remember it by the 7 P's. The first one is pain, and that's a classic sign of acute compartment syndrome is severe pain, especially when the muscle within the compartment is stretched. It diffuses and it's really intense, and it's increase with movement, touch, pressure, or stretch. So using or stretching the involved muscles increases the pain, and the muscle may feel tight or full. The second P in the 7 Ps is the paresthesis, where you lose the feeling below the compartment syndrome area, and that just radiates further away. You'll feel tingling or burning sensations in the skin, and this is where the nurse should really check the capillary refill again, just to check with the circulation. You can have numbness or paralysis, which are really late signs of compartment syndrome, and they usually indicate permanent tissue injury. The third P of the 7 Ps is pain with passive stretch. You can have severe pain when muscles in the affected compartment are stretched. The fourth P is pressure, where you can have palpable tenseness in the affected compartment. It feels really tight and sometimes even warm. They do not recommend palpation for diagnosis. The fifth P is pulselessness, which is least reliable and is often a very late stage since compartment syndrome affects the microvasculature. Typically, major vessels are not affected, but if you have no pulse, that's always a bad sign. 6 is pallor. They'll start to be looking a little pale. 7 is the paresis, weakness, or paralysis. In acute compartment syndrome treatment, since it is a medical emergency, you're going to need to do immediate fasciotomy and debridement, and emergency treatment may be required to save an infected limb. Branching from compartment syndrome, it can also lead to rhabdomyolysis, which is a life-threatening complication of severe muscle trauma with muscle cell loss. And it is a sudden breakdown and necrosis of skeletal muscle with the release of large amounts of myoglobin in the blood. So you'll have myoglobinemia. And with decreased myoglobin, you'll probably result to acute renal failure. Your urine will be dark because of the excretion of myoglobin. So you'll have myoglobinuria. You can have hyperkalemia, and there's a classic triad of rhabdomyolysis, which is muscle pain, muscle weakness, dark reddish brown urine. The cause of this could be burns and heat stroke, alcohol binge, a crush injury, which I will talk about in just a minute. You can have a drug overdose with statins, electrical shock, and poisons. And the treatment for rhabdomyolysis is rapid IV hydration to maintain adequate kidney flow. And then what could result from this is hyperkalemia, which may require temporary hemodialysis because the potassium gets out of the cells. Some early signs of rhabdomyolysis, which would be hyperkalemia, hyperphosphatemia, hypocalcemia, hyperuricemia, acidosis, and some late ones would be acute renal failure, DIC, compartment syndrome, and infection. Rhabdomyolysis can also cause crush injury or crush syndrome, which is defined as compression of the extremities or other parts of the body that causes muscle swelling or neurological disturbances in the affected areas of the body. So normally muscles can withstand approximately 4 hours without blood flow before the cell death occurs, but after this time, cells begin to die. And a major problem is that we're not recognizing the potential for its existence and removing the compressive force prior to the arrival of medical assistance, which is unfortunate because these effects are systemic and they cause traumatic rhabdomyolysis. And then the release of this is potential toxic muscle cell components and electrolytes in the circulatory system. Crush syndrome can cause local tissue injury, organ dysfunction, metabolic abnormalities, including acidosis, hyperkalemia, hypocalcemia, and these toxins may continue to leak into the body for as long as 60 hours after the release of a crush injury. The toxin outcomes from a crush injury include creatinine phosphokinase, and CKMM, which is specific for muscles, histamine vasodilation, bronchoconstriction, myoglobin renal failure, potassium, which would cause hyperkalemia, which would cause the dysrhythmias, and purines, uric acid,
hyperuricemia, which causes further renal damage. Crush syndrome signs and symptoms would be compression in longer than 60 minutes, the involvement of a large muscle mass, the absent pulse and cap refill return to the distal limb. And at this time, it is significant for the nurse to do a cap refill check just to make sure the body part is receiving adequate perfusion. You will also see pale, clammy, cool skin, a weak or rapid pulse, and usually an absence of pain in the affected region. And there's sometimes the onset of shock. And so, in order to make everything tie together, I'll just say that crush injuries can either cause compartment syndrome or crush syndrome. And crush syndrome is a reperfusion injury, which is usually a result of traumatic rhabdomyolysis. And rhabdomyolysis can also cause compartment syndrome. And this concludes the discussion of my concept mapped about musculoskeletal injuries. Thank you for listening.